Hi, I'm Kaustubh Shivshankar Shejole, and I will be presenting our survey looking at radiology report generation through a causal lens. So, motivation for this problem is that radiology is an extremely important diagnostic tool and it saves millions of lives per year. But there is global shortage of radiologists, for which researchers have found these deep learning techniques to help, such as encoding images and using LLMs to generate text and incorporating knowledge graphs to improve accuracy. And this is known as automated radiology report generation. But we know that these systems are vulnerable to biases which stem from the RRG process, mainly due to spurious correlations. So, what is the solution? This potential solution is causal inference, which is famous for dealing with such spurious correlation by identifying true cause effect relationships. So, coming towards contributions, we perform a systematic review of the RRG pipeline. We model RRG as a causal inference problem, and we provide a clear categorization of mitigation approaches based on the level of intervention, such as data level, model level, and evolution level intervention. Fourth contribution is that we examine the biases in public medical imaging datasets and evaluation metrics, and we argue that broader demographic coverage in datasets should be there, and better causal aware metrics should be developed to make RRG more fair and reliable. So here is the RRG pipeline. So there are some RRG stages such as data collection, pre-processing, and like evaluation through matrix deployment. And in each RRG stage, there are biases which can get which can enter, and we there here the causal inference can help and mitigate bias to a considerable extent. So biases in RRG can be due to these factors, which is radiology practice and reporting, medical imaging, and large language models. So, starting with radiology practice and reporting. Uh, Firstly, we will encourage reader to go through our paper for detailed explanations. Here, we will try to summarize in we will try to summarize in brief. So, alliterative bias is when we rely on our prior reports, which perpetuate errors to a chain. And framing bias is when our interpretation is skewed by limited or misleading clinical history, which is provided by a referring clinician. Availability bias refers when we overestimate easily record or recent cases. Similarly, anchoring bias is when we stick to our first diagnosis, even if new evidence proves that it is wrong. Inside bias is where we overestimate predictability after knowing outcomes. And similar such biases, such as blind spot bias, refers to a bias when we are not able to identify our errors, but we can identify others' errors. Scout neglect bias is where we overlook findings in preliminary scout images because pathology is not expected there. So, after that, in medical imaging, there is sampling bias where like are datasets fail to represent the full diversity of patient populations, then or other demographics, and then there is annotation bias where there are some errors and there is over focus on some kind of diagnosis than the other ones. And then there comes propagation bias, which is because of data quality issues, that is missing metadata or transcription errors. And then comes acquisition bias, which is because of the differences in scanner types or imaging protocols. And then in LLMs, we know that hallucination is a famous problem where in this context it refers when LLM can describe a condition which is not present in an image. That is, it may generate findings which is not directly linked to the input information, which is very serious concern. Then comes dataset imbalances, as we saw that LLMs may learn spurious correlation because of datasets, and this can reflect in the reporting phase. Then comes socio-demographic bias, where studies have found that LLM outputs can vary by patient demographics, and this concerns RRGs. Then for mitigation strategies, firstly we can categorize them on the basis of the data level intervention, where there comes causal sampling, that is, it creates balanced distribution using intervention that breaks confounding. Then comes synthetic data, that is using synthetic data to explicitly decorrelate confounders. Then is model level intervention, that is deconfounding and debias prompting. These are the two techniques. And on evaluation level intervention, there are counterfactual simulation, interpretability, and targeted audits which are used. And so bias mitigation through causal inference is this is the summary of tables that which biases can be tackled using causal inference. So fully mitigatable biases are framing bias, availability bias, and inside bias. Partially mitigatable are scout neglect and acquisition, and non-mitigatable are label biases, large training imbalances, or LLM hallucinations. Because causal relationships are not interventionally accessible here. So such analysis is presented in paper. So we encourage to go for it. In medical imaging datasets, there are various biases such as geographic bias or age bias, where we can see that only a limited amount of data is present. And similarly, for age bias, there is like we found that only some limited amount of age group is present, which can hamper the algorithm learn. So after that, there is a need for causal aware metrics because evaluation metrics such as Blue or ROG or Meteor and CIDER are actually they measure textual overlap but are agnostic to causal structure. As a result, these metrics cannot detect or correct biases arising from confounding mediation or selection bias in the data. So there are some causal aware metrics which are proposed in RRG literature, but these metrics also have some of the problems associated with them, which we discuss in paper. So we encourage the community to go for better and better causal aware metrics as well. So our conclusion is that RRG in bias in RRG is due to spurious correlations, and causal reasoning is a key. So these are our contributions, and the guidance we provide is that we can increase dataset demographic coverage as well as we can develop better causal metrics for fairness and reliability. And these are some of the future research directions where we can use RRP for similar such, where we can use causal inference for similar such fields such as medical report summarization, or we can use causal metrics for free from text or joint causal structure of visual linguistic pipelines and causal auditing and intervention. Our limitations are that we only refer to published research in RRG, and we actually provide a systematic review, and the uh, the statements need to be empirically validated. So these are the references. Thank you.